Hey team, let's continue our conversation on COVID-19 pathophysiology. All right, when we left off last time, we were talking about severe COVID and its effect with ARDS. So ARDS absolutely requires a lot of intervention. So it's really challenging. There's different forms of ARDS, and it's based on the degree of hypoxia. The physicians clarify all of this. But basically, you can have new onset respiratory failure, or they already have impaired respiratory function from a previous condition, and then it gets a lot worse. There's a lot of ways to get there. But ultimately, the highest risk factor for developing ARDS appears to be age, unfortunately. So once they have the manifestation of this, the train kind of keeps rolling. So knowing that, you really want to be aware of these risk factors so that these folks can make decisions with behaviors and interventions and stuff so that they are less at risk of getting ARDS, because that's a challenging one to get back under control. So these are going to be folks, again, age, right? Comorbidities, we're going to look at that here in a second. If they present with a particularly high fever, or if they have a history of smoking or obesity. So let's look at these risk factors here for a second. Increasing age. So this is age 65 and older. Again, it turns out risk is the strongest risk factor for the onset of severe illness in COVID, and particularly for ARDS. Behaviors, smoking, current and former. I'm not sure how much former means, like if it's a decade ago or if it's, a week ago type thing, what kind of former time frame we're looking at there, but current and former. And then physical inactivity. This is an interesting one. To look at this study, they had a larger, I think this was at the Kaiser system out in the West Coast. And they looked at folks who were more likely to have a presentation of severe illness and found physical inactivity to be an independent risk factor. So there are a couple different manifestations of this. One is working out or exercise, like specific exercise that's less than 60 minutes per week. Or MET equivalent of less than, or actually an MET equivalent of 500 to 1,000 MET minutes per week is associated with reducing the risk. So if you're looking to be in the lower risk category, like maybe, you can't help getting older type thing, then to prevent that, you would need to hit 500 to 1,000 MET minutes per week. But yeah, if you're only working out, a little bit, it's unfortunate. But at the same time, 60 minutes is a really doable number, right? So you can try to see it like more than one way. And that, if you work out for, 90 minutes, that's pretty close. So the use of medications can also be a factor which creates risk for onset of severe illness. And particularly it's immunosuppressive medications, which makes sense, right? Again, the immune system being the force that must defeat this a very powerful pathology. Now, I've got the list of conditions that the CDC, upon performing a systematic review of the literature pretty recently, says are factors that increase your risk. So these are pre-existing conditions that mean you're more likely to have severe COVID. Name an organ system practically, or name a condition. Even pregnancy can be a factor. A lot of genetic stuff on here, a lot of inflammatory stuff. So the summary, the takeaway here is that you can cluster these almost any cardiopulmonary illness by default, right? Many chronic illnesses. It's hard to find a category of chronic illness that isn't in here. Even things that don't seem related, like neurologic conditions such as dementia, are on here. Any sort of immune suppression status. So that can require a little bit of interpretation. So anybody who's received an organ transplant, or anybody who has a condition of hyperimmune activity or autoimmune activity, as well as anybody with a hyperinflammatory condition. Those are all folks who probably are taking meds that need that suppressed, right? So there are conditions here that you wouldn't think necessarily fall into immune suppression, but unfortunately some mental health conditions do fall into that area. So depression can play a metabolic role in immune function, and that can create some risk factor for having a not great immune status that leads to increased risk. So things that you might expect more so, though, are things like heart failure or asthma or active cancer. I know that other factors that can be really high risk include active chemotherapy, and I know that folks with diabetes and organ transplant are at particular risk for this. Okay, so again, outside of the lungs, there are many, many other systems that can become injured, and the mechanisms of injury fall into our intro to patho type things with, direct viral toxicity. In other words, the alveolar cells were injured. Yeah, well, COVID can get other places as well. And then all of that thrombotic inflammation type activity can damage any other cell that it messes with. We now know, especially in long COVID, that there can be dysregulation of your blood pressure system. So that's going to be your RAS, your renin, angiotensin, aldosterone system. And dysregulation of the immune response in general can create issues outside of the lung. So on medical examination, what's often performed is a lot of lab testing. So one is they do PCR testing to confirm that the disease is present. We're going to do a lot of labs, and there's a couple labs here that are of particular interest. Plenty of imaging, trying to see what's going on, and we'll take a look at a couple of imaging findings. I'm not necessarily going to test you on these, I'm just demonstrating to you the effect on the lungs. Okay, so there's one lab that's really interesting. This is ferritin. So you may know that ferritin is involved in immune regulation because it's part of life, right? You have to have ferritin in order to have cellular replication. So this is actually also a key mediator of immune dysregulation. So it's a pro-inflammatory mediator, and it's related to the activity of a cytokine storm. So basically, if a patient has really high ferritin levels, that's associated with greater mortality and greater severity of the disease, right? So in one study, this is a small study, but it gives you a sense. Severe COVID patients had these 200s levels, and very severe had over 1,000. So I'm not going to ask you specific numbers like this. It's more of the trend. Higher ferritin means higher risk of disease severity and therefore higher mortality. D-dimer, another one that you may remember, is being related to clot formation. Higher D-dimer is a really powerful indicator of things are not going to go well because it's also associated with inflammation. Remember that inflammation creates clot risk, and D-dimer reflects that. So what's interesting is in patients that start to do well, your inflammatory markers like ferritin and all those interleukins they can look at and D-dimers drop at the same time. But what's kind of weird is in some patients, the inflammatory markers drop, but D-dimer stays elevated. And these are your patients who end up on aggressive anticoagulants even after the condition is done, and they might be on it for quite some time, waiting for those D-dimer levels to come down. So higher D-dimer, higher ferritin, higher risk of a poor prognosis. Okay? Let's look at some images here to kind of see what's going on. Okay, so this individual here is an early diagnosis, and they're showing one thing that we call a ground glass opacity. So I'll take out the pin here so you can see it. The arrow's trying to show it to you. Okay, so what you've got here is this bit here, this kind of ghosty bit look. This here. So see, all the rest it's black, and this is kind of more of a gray bit here. So that is a GGO, the ground glass opacity, and that's showing some of the flooding, basically, that's starting to occur in the early stages of infection. As the severity increases, it starts to increase as well with the ground glass opacity findings. So that's what you're seeing here. Note that these areas are getting larger. Oh gosh, yeah, you got it here, here, kind of all over the place there. So quite a bit there. And now you can start to see where the fibrotic processes are starting. And you can see these kind of wild looking lines here. Look at this kind of strangeness here. This is what they sometimes call crazy paving. And that's what's getting shown in the black circles there. So this can be bronchial thickening. This can be just fibrotic processes in general. This shows you that things are not going well. So let's look at one more. So that was CT earlier, yeah? This is on X-ray. So this is also showing the ground glass opacities. And note that, so here we have like the middle bit and then the lower parts of the lung. Notice how the ground glass opacities are increasing, and it's all just kind of hazy. And then I want to show you one where you can see the progression. So in A, they happen to have a patient. This is an interesting case that came out pretty early on. I mean, you can see the date there is in 2020 on this, when I pulled this. So when this was published. So they happen to have a patient who was having various forms of workup, and so they happen to have an X-ray before the person had COVID. So that's it all the way on the left in A, and notice that you can very easily see all the way through here, no problem, right? And that slowly starts to go away as you have increases in the GGOs and all the way into here, which is severe status. So at this point, this person is intubated. And if you look closely, you can actually see the intubation tube, the endotracheal tube, and the central lines, as well as the NG tube that they were using to feed this person, because they're knocked out. So this person is having pulmonary support. So this is kind of the progression as it continues to increase. And this is what's truly terrifying is, you know, a lot of times people enter the hospital when they're awake, and they're even awake just before it's time to intubate. So they have to be sedated, and they never wake up. So this is honestly what led to a lot of people leaving healthcare, is that happened over and over, right? They could not stabilize these patients. They could not reverse the inflammatory processes happening inside the lung, and the lung over time shut down. So thankfully, we now have modern treatment. So the oxygen support is the same. This technology hasn't really changed a whole lot. If you're lucky, you only need a high flow nasal cannula, or you need to be intubated with mechanical ventilation. They'll put a tube down your throat, hence the name orotracheal. They now have much better medication for doing this. So this is kind of funny. This is dexamethasone. Sometimes you hear it called Dex. It's a very cheap, old corticosteroid. It turns out it's very effective at helping with mediating inflammatory processes to improve outcomes in severe COVID. So there's rules and categories and algorithms for what drugs to give based on severity and presentation, but that's for physicians. We kind of just want to be familiar with what these drugs are supposed to do. So then we also have two classes of drugs that are immune modulators. Anytime you see that NIB, that MAB at the ending, it's doing something with the immune system, most likely suppressing it. So both of these are inflammatory inhibitors, and one of them you actually recognize. So with IL-6, tocilizumab and baricitinib. So you may know these names, you may not, but it's just to give you the sense that basically what they have to do overall, the medication treatment, this is what I want you to know, it turns down inflammation because it gets out of control. That's the big thing here. So it gets out of control to the point where the lung floods, okay? It's not that we don't want some inflammation to turn off and destroy or actually not to turn off, but to destroy the pathogen, but we can't have it so aggressive that it floods the lung, because when that happens, the lung can't function. In addition, we found that prone positioning was particularly effective in this population, which makes sense. That was already known to science in the management of ARDS, but this became something that was well known. In PT, we were familiar with this, and I think a lot of intensive care folks were familiar with this too, because it is a strategy that's used sometimes, but it became like the norm. So when you get to your clinical management coursework, you'll learn about how we have to manage sometimes the issues related to having been in prone for so long. In rehabilitation, we are kind of the star. So once they get stabilized, with any luck, we get in there and we get in there well. The cardiopulm section of our profession has done an amazing job of summarizing all of the interventions at various levels of acuity and severity and presentation and factors to consider in their PACER series. So this is a series of lectures they have posted on that link there that you can watch and listen to. I think I watched all of them back when they first came out, and then I watched them again the next year. And I haven't refreshed here in a minute, but they're amazing, and they'll really help steer you if you're interested in working more acutely with COVID patients, or if you want to be better at it when you get in there. So, okay, thanks, team. Look forward to seeing y'all in class.